So most of us who live in, who stay in this room would probably know that there is a lot of challenge in working on rare disease, both in the diagnosis and making the access for the patient, especially in resource-limited country. And today we will hear a lot about rare disease, how to get the access to the patients. And we have several speakers, and I would like to introduce the first one, Dr. Saumya Jamuar from KK Women and Children Hospital. He's also the lead PI for the Singapore Undiagnosed Disease in Children, and also the director of Sing Health Duke NUS Institute of Precision Medicine. And he received many awards, including the 2021 National Medical Research Council Clinician Scientist Award. And his talk title is Singapore Undiagnosed Research Endeavour. So over to you.
Hey, thanks, Dr. Duang. Thanks for the very kind introduction, and thank you to the organizers for letting me speak. So I think for many of you who are coming to Singapore for the first time, welcome. I hope you had some time to visit and enjoy the many things that there are in Singapore. But I'll kind of go into something that's not so much from population level, but rare diseases. Sometimes they're neglected because they're considered rare, but have a tremendous impact. The thing about Singapore is when you apply for funding, you need to have a sort of catchy title. So I came with sure find, because I was definitely sure that I'll find something. Right, so that's the first thing about Singapore. The second is, what is a rare genetic disease? And there are different definitions across the globe. In the US, it's a disorder that affects less than 200,000 Americans, whereas in the European Union and Singapore, it's a disease that affects less than 1 in 2,000 individuals. But while they're individually rare, cumulatively they're very common. More than 350 million worldwide are suffering from a rare disease. That's about 2% of live births and 5 to 8% when you look at adults as well. 80% of them are genetic. There are more than 7,000 rare diseases, and 3 new rare diseases are being discovered every week, and that number keeps growing, right? But the challenge is that because they're individually rare, there's a long diagnostic odyssey where the patient goes from one doctor to another, one hospital to another, one test to another before getting the final diagnosis. And this was a paper just published by the European Reference Network, which showed that even today, with access to technology, there is a diagnostic delay of 4.7 years from when the patient first presents to the healthcare system to getting a diagnosis. So we are still not there yet. We're still way off in terms of utilizing that technology to bring an end to the diagnostic odyssey. It's way worse here in this part of the world where a lot of tools are not so easily accessible. So I trained under Heidi back in a decade ago, and then came back, set up the Singapore Undiagnosed Disease Program together with a lot of collaborators. Some of them are in this room. The idea was to use cutting-edge genomic technologies at that point, and then collaborate, because these technologies were there in the research institutes, but not so much in the hospital. So we wanted to connect. And so we call the program Bridges, because it was a bridge between the patients and the genomic research institutes. But the most important part of our program was that we wanted the program to benefit the patients directly and improve their health outcomes. So over the past decade, we have recruited more than 690 families. So a small number, but we are a small country. We've got a diagnostic yield of 49%. And more importantly, 27% of them actually had a change in management in terms of what was being done for them and what was done after the diagnosis was made. So again, this is a no-brainer in terms of change. All of them who got a diagnosis got an accurate genetic counseling. I think that's relatively straightforward. But 80% of them, there was a change in diagnostic strategy. And this change was maybe the individual was meant to go for a bone marrow aspirate to investigate, and then we got the diagnosis, so that kind of changed. But in a third of them, there was more specific diagnosis, and I'll cover one of them. But we could offer treatment based on the molecular pathology of that individual child. So I'll start off our 10-year journey by sharing some of the highlights. And so one of them was this novel gene discovery, which was it's a recessive form of epileptic encephalopathy caused by mutation in UGDH. So the family came to my clinic in 2015, had a sort of a non-syndromic presentation, development delay, unsteady gait, speech impairment, abnormal EEG, and epilepsy. And we found one variant in UGDH, which was a missense. But this gene had never been associated. What does this gene do? It's a precursor for forming proteoglycans, and proteoglycans form extracellular matrix, important for development of the brain structure. So we said, interesting, let's follow this up. So the first thing we did, again, is we reached out to our friends globally, and I quickly identified 4 other families who had variants in UGDH, who had the same phenotype. So we then went on to do functional work, and we proved conclusively that there was, in patient cells, there was reduced production of NADH and hyaluronic acid, as well as abnormal development of the cerebral organoids, suggesting that this was a disease, these mutations were relating to disease pathogenesis. So this was the first study, but more importantly, from a patient perspective, brought closure and did a diagnostic odyssey. But that's where the journey for this family ended at that point of time. Since then, we've gone on. We're trying to, one of the families set up a foundation. They're based in DC. And now we're trying to raise funds so that we can fund research to build therapeutics. But for another family, we could actually do this. We could improve their management by giving a targeted therapeutics. And this was sort of, in the middle is a timeline of the child being in the hospital. So each arrow is an infection that the child have, and each color is a different type of microorganism. So it's a bacteria, viral, fungal, mycobacterial. Exome sequencing identified a novel variant in NF-kappa B inhibitor alpha subunit. This diagnosis was made. This child had never gone home since day 6 of life, stayed in the hospital. When we did the exome sequencing, we made the diagnosis at 9 months. We had a firm diagnosis. Bone marrow transplant was curative. So she went for transplant and went home after 1 year of being in the hospital. I'll skip that, but unfortunately, 12 months later, her symptoms recurred. And this time, because we had functionalized this variant in the lab, we were able to go back and very quickly realize that it was a interleukin-1 driven process which was causing excessive granulopoiesis. So because of that, there is an anti-IL-1 agent called anakinra, and we could give that, and actually with that, we were able to see an improvement in her immune dysregulation and improvement in her symptoms. So this was one of the first sort of proof of principle in our setting where we could give a patient a treatment based on the exact molecular diagnosis that the patient had. But obviously, that's moved much further ahead, and there's precision therapeutics. So this is Mila. I don't know. I'm assuming most of you know about her or her story. She had Batten disease, and she was the first one to be given a patient-specific oligonucleotide to treat her Batten disease because she had a splicing variant. And what was remarkable about this was that this was done within a span of a year, which, as we know, in therapeutic development never happens. So this was remarkable, and to be honest, since then, there haven't been many success stories. So not many patients are dealing. But what that has done is it's galvanized clinicians, scientists who come together to form this N-of-1 collaborative. And we are part of this collaborative, and more recently, I've got some funding to develop antisense oligonucleotide for one of my patients. So we'll be working on that and hopefully contribute to this. Moving beyond, so the story starts with discovery, treating, and being more precise with the treatment. But we are only diagnosing 40 to 45, 49% of our patients. Majority of the patients are not getting a diagnosis. So what can we do? So how do we expand? And so some of you attended the lunchtime talk with long-read sequencing. So this was a 15-year-old child who was admitted, and this was the 11th child that was admitted, was recruited to the program. And so back in 2014. a neurodegenerative phenotype and passed on 6 months after presentation. We threw everything that we had at him, and even after he passed on, we threw whatever we could get access to. He remained unsolved. Finally, in 2022, we had access to PacBio long read, and we found this 7.5 kb expansion in BEAN1. This expansion is associated with spinocerebellar ataxia type 31, a very rare form of spinocerebellar ataxia. But this expansion would not have been picked up by traditional short-read sequencing. It took us a while to actually verify this on long-read PCR as well, because it would selectively amplify the smaller, shorter allele, but we actually have confirmed that this expansion did occur, and the process of writing this up. The next thing in terms of technology, and this is sort of the, where we are in terms of AI. So this is the man versus machine kind of a comparison. So I'm standing next to a 3D camera. And the idea is, can we use 3D photography to help with dysmorphology assessment? So all of us, when we, as a geneticist, when I see a patient, I kind of try to pick up what are the specific syndromic features that they have, the signature that they have, so that I can diagnose that symptom or that syndrome. But most of the time, not very successful. And between geneticist to geneticist, there is variability. So you will not get the same response. So it's something like ultrasound, where it's very operator dependent. So can we take that subjectivity away? So this was a project in collaboration with with a group in Perth at Curtin University. They developed this tool called CliniFace. What CliniFace does is it takes the 3D photography and extracts 57 measurements and then plots them against the growth curves to see what is outside the 2 standard deviations on either side, and then gives you a dysmorphic assessment. So this is what it looks like. It can kind of say, okay, these are the features. Now you have the feature. It's a standardized capture of the phenotype. You can bring that to the next level of analysis. The challenge with that was that this was based on, just like everything else in genetics, Caucasian data. So when I put an Asian face on that, everyone has a syndrome, right? And so on average, when I used European reference range, we had 6 dysmorphic features for every patient, that every individual, and these are healthy individuals who are coming for asthma care, gastroenteritis, upper respiratory tract infection, but they were dysmorphic based on this. So over the course of the year, we actually recruited 1,200 healthy children across the different age groups, so about 20 to 25 in each age group, so 0 to 1, 1 to 2, both males and females. And we developed new reference curves for the East Asian or Chinese population. And once we used those reference ranges, the numbers dropped from average of 6 to less than 1. The 1 is there because this is for telecanthus, and that's because the software was using a measurement that was based on, again, Caucasian data. So now they have gone back and rejigged it, so actually it's gone back even below 1, but that's kind of where we are. And this is, again, goes back to the whole concept of we need data, but we need data beyond genetics. We need data from photography. So as expected, because these were reference ranges for the East Asian population, when we did that for the Indian and the Malay, we didn't see any difference. So now we are in the process of recruiting healthy Malay and Indian patients. But if any of you is interested to contribute, please let us know. We are more than happy. This is an open access tool, so anyone can download it. The only flip side is it needs a 3D photograph. So you need to purchase that camera, which is about $20,000. It's still cheaper than hiring me. So, and it does a much better job in giving you the diagnosis. So I think it's a good investment. But before we do that, we need to build reference ranges. So please, if there are collaborators, please reach out to me, and I'll be more than happy to explore this. But this is very critical. The next thing we do is this: we cannot do this alone. You can build things, but you can only go that far. You can go further if you, and this is something that Heidi kind of exemplifies very well. All the networks that she's built. And we've tried to join many of them, but because of time zone difference, sometimes we can't, but we are. And so, as you see, the Bridges program was focusing on KK Hospital and the research institutes. But then we expanded it, and we expanded it to include the adult hospitals because there are many undiagnosed adults with rare diseases that are not being picked up. They are seeing the nephrologist, they're seeing the cardiologist, they're getting excellent care for their heart, their kidneys, but nobody is looking at them as a whole, and so they get missed. So in one study, what we did, we extracted 1.28 million patient records from 3 hospitals, and we just said, okay, pick up, are there patients with undiagnosed Fabry disease, because it's a multisystemic disease? On a baseline of 4 patients that we had, we identified 2 more that could have Fabry disease, but were not identified. This is just one rare disease. Multiply that by 7,000, you definitely have a lot of patients in the hospital system that could be picked up and that were not. So, on the right side is all the hospitals that we work with, and on the left we went beyond local, so global, so working with different international initiatives as well to see how we can help best support our patients and get them the diagnosis that they need. So one such diagnosis came through this. This is an undiagnosed hackathon. So those of you who have patients who are undiagnosed, this is run by the Wilhelm Foundation, and it's part of the, they collaborated with UDNI, the Undiagnosed Network International. And this was the second hackathon, just in June this year. They brought in about 100 different, a multidisciplinary team, so geneticists, genetic counselors, bioinformaticians, lab scientists, put them together and put them into teams and said, okay, here are the unsolved cases, solve them. And so one of my patients, who was, I think, CDS 10, so the 10th patient, again undiagnosed for 10 years, we found an answer. And the answer was published the week before. And it was one of the papers that Dame Sue Hill presented on, the non-coding RNU42 gene that was identified through analysis of Genomics England database. So we had one patient. So we're like, great, we've solved him. We came back, we looked at other patients within our data undiagnosed, we found a second patient. So again, participating in these networks has actually allowed us to accelerate that diagnostic process and help not just the patient who was participating in the hackathon, but other than that. So we'll continue to do that and go from there. What we are doing now is we've got this capability in our tiny island in Singapore, but we have our neighbors in ASEAN, or the Southeast Asian countries. So we've got funding to build this network in ASEAN. We call it G4KA, or Genomics for Kids in ASEAN. And the idea is we want to improve access to genomics across the region for these countries. But more importantly, we want to build regional capacity. It's not about just diagnosing the patient, but we want to build an infrastructure that goes beyond diagnosis to care, so that these patients actually have better care. And then understand what is the genomic epidemiology in our part of the world. So when we looked at our data, we identified citrin deficiency. And I don't know, I don't want to do a poll, but most of us would not have heard of citrin deficiency because it's an East Asian disease. And because it's an East Asian disease, it's not in the medical textbooks because they are based on Western data. Again, a bias. So we found that this was the commonest treatable inherited disorder in Singapore, right? And we had no idea what it was, right? So now we are working in the lab to see how we can build newborn screening programs that can actually diagnose these patients with citrin deficiency. So over the past year, we have had 74 cases, and that's the distribution of nationality. The Australian lives in Singapore, that's why they're here. They're not, because we are not that good. We don't compete with Australia, but yeah, if they're in Singapore, we can provide access to that, right? The last part is when we do sequencing, we solve, and I think, again, Heidi, you're doing this fabulous work of helping us reclassify variants of uncertain significance. But there still is a big number of variants of uncertain significance that remain. And so what we said was we need to find researcher. And the problem was that every time, for every variant, you had to find a researcher, write to them, and see if they would be interested. it was a lot of resource requirement. So we copied the Canadian model, and we called it the Singapore Rare Disease Models and Mechanism Network, which was a network that connected physicians with PIs within Singapore. And we were quite fortunate because everyone saw the need and everyone was onboarded. So we actually managed to connect all the hospitals, all the research institutes, and we've got PIs. So if anyone's interested, the list of researchers and clinicians is there, and you can reach out to them. And now we're going to work to see how we can go to variant level matching and other such networks to augment that. One of the things we did was we are now part of the RDMM International. So it not only connects researchers and clinicians within Singapore, but it connects researchers and clinicians internationally. So if you have a gene of interest, you put into that network, and you get connected instantly to a PI who may be working on that gene. So something. Okay, yeah. The last thing is, in this room, I see clinicians, I see scientists, I see counselors, but I don't see that many nurses. And if you imagine a patient with rare disease always will see a nurse. They may not see a doctor, they may never see a geneticist, but they will see a nurse. So can we leverage on the largest healthcare workforce to provide better care to our patients with rare diseases? So last year, we set up the Global Nursing Network for rare and undiagnosed diseases. And this is meant to just be a network, a platform for nurses to connect with each other. They don't need to be genetic nurses. They can be any nurse, because a nurse will see a patient with rare disease. They just won't recognize that's a rare disease, but they will take care of that patient. So we created this network. So when you go back, please do encourage them to join. We have nurses from 48 countries. We started last year. We already got nurses from 48 countries, more than 450 nurses. And at this point, some of them are sitting on the other side of the island trying to build the Asia-Pacific chapter of this nursing network. So if anyone's interested, again, either just scan, go to the website, or come and chat with me. Okay. So I'm just going to come to the end of my talk. And this is what I learned as a physician, is to cure sometimes, to relieve often, and to comfort always. And it's best summarized by a letter from one of the families that went through this process and found the answer. So it's a long letter. So it starts off with saying that they've been living all these years wondering what was wrong with their boy, not able to get a conclusive diagnosis, were times of frustration, future looked uncertain to us. Finally, they got a diagnosis. In 2015, it was a new diagnosis called Pura syndrome. Thanks to social media, one of the few benefits of social media, they were able to connect to a parent support group. And so now they were able to find that support that they've been yearning for years. The future didn't look so uncertain for them from there. And then they ended up saying, hope this continues to help other children and their diagnostic odyssey. And so we took that to the next level. We collaborated with our local media partner, MediaCorp, and created a 4-part docuseries called Undiagnosed. But my hope is that these patients are diagnosed, and hopefully we can do that. Not just my work, but it's a whole team. Not everyone's been named, but I try to capture as much. A lot of funding. So thank you, everyone. Some of them are in this room, but thank you.
Thank you so much for your beautiful work and talk. I would like to remind all the audience that please participate in Q&A sessions by using the Pigeonhole Live and log into the Pinhole using the password shown on the screen. And the next speaker, Dr. Claudia Gonzaga-Jauregui. She's from the National Autonomous University of Mexico, and as a principal investigator in human genetics and genomics at the International Laboratory for Human Genome Research. She contributes a lot to large population genetic studies such as HapMap3 and also identification of several normal single gene diseases. Claudia is also an advocate for inequitable access to genomic sequencing for the diagnosis of patients living with genetic disease in resource-limited countries. So Claudia, over to you.
Thank you. Thank you for the introduction. Well, I'm very happy to be here, and thank you to the organizers, and also very excited to hear everything that we've been hearing about in the last day and a half. And I would love to stand here to tell you all of the sequencing that we're doing in Mexico and all the long-read sequencing that we're doing and other omics and that, but unfortunately, I will not. So the previous speaker gave already an introduction of what we consider rare diseases. Basically, these are conditions that occur at a low prevalence in the general population, and as mentioned before, there are different definitions depending on the different countries and regions. In Latin America, so I won't talk about the US and Europe because that was already mentioned, but in Latin America and the Caribbean, which is conformed by 33 countries, there's not a consistent definition of what a rare disease is. So in Argentina, Chile, Mexico, Panama, and Uruguay, the definition is less than 5 in 100,000, which is similar to the in 10,000, sorry, which is similar to the European definition of 1 in 2,000. But many other countries don't even have a definition of what a rare disease is, and this obviously impacts the access of patients to services, to healthcare, to treatments, as it is not legislated or regulated. Also, there's a variable number of rare diseases that are recognized in the different countries. So until last year in Mexico, there were only 23 rare diseases recognized by the healthcare system. So last year in July, the Mexican Health Council recognized the 5,500,000 diseases in the WHO list. But between recognizing them and actually making treatment and diagnosis accessible for patients, there's a big gap. So as mentioned before, these conditions affect about 6 to 8% of the world population, or about 350 million people. In Latin America and the Caribbean, we calculate that there are about 50 million people affected by rare diseases, but we don't know the exact number. And similarly, in Mexico, we don't know how many, but we estimate that there are about 10 million Mexicans that live with a rare or low prevalence condition. And one point that it's interesting in these estimates of how many people are affected, that particularly in Latin America is relevant to point out, is the number of indigenous people that live in a region. So Latin America is home to 50 million indigenous people, and given these estimates, we think there are about 3 to 4 million people, indigenous people, that live with a rare condition, and most of these people are vulnerable populations that have little access to healthcare, that have a higher burden of disease, sometimes because of their sociodemographic history, inbreeding or isolation, geographical isolation, and again, many of them live in remote communities where they don't have access to tertiary or healthcare services, basic healthcare services. As we know, 80% of the diseases are genetic, and we know the molecular cause of more than 6,800 of these disorders, so we can diagnose these conditions. And only 5% have an available treatment that is approved currently. There's another 5% of diseases that have treatments that are being developed or are in different phases of clinical trials. And as we see more development of molecular therapies, we'll see more of these conditions possibly having therapies. However, in order for patients to have access to these therapies, they need to have a molecular diagnosis. So I think we can all agree in this audience that genomics has had a huge impact in how we diagnose and research rare diseases. So this graph shows the discovery of new disease-associated genes from the very first publications, of single gene disorders in 1986 to to 2019 when this graph was put together. But in orange, you see conventional methods like linkage or candidate gene analysis, how these genes were discovered. And then you see in blue, starting in 2010, when we started implementing next generation sequencing with exome sequencing and whole genome sequencing to identify the causes of genetic diseases, and how the application of genomics for the study of rare diseases has impacted the discovery of new genes associated with these conditions, with about 200 to 300 genes per year since 2010. So why is it important to have a diagnosis? I mentioned before, access to therapies is one of those aspects, but also early interventions that may change the course of disease. Also avoid adverse outcomes or even adverse interventions that may be recommended to some patients, but once we have an accurate diagnosis, they are not recommended anymore. I mentioned access to effective and sometimes personalized, as mentioned before, therapies that are designed to specifically address the molecular defect in these patients. Planning for the future in terms of knowing what's the disease progression and the natural history, giving answers to the patients, to the families, and that can also help for family planning. And ultimately also developing and implementing public health policies if we know which diseases are more prevalent in which populations and which variants might be more prevalent in these populations. We can design screening programs and early detection programs. And ultimately, the goal is to implement precision medicine. So in Latin America, and this is also true for many other resource-limited countries, some of the issues that we have with implementing genomics for rare diseases is that it's this vicious circle where we have a lack of awareness in primary care physicians. Patients don't get referred to geneticists. So as part of the projects that we're running, we also have the Mexican Registry for Rare Diseases, and we see that 70% of patients have been told that their disease is genetic, but only 30% are being referred to geneticists. So they are not even getting testing when they need to be tested. Also, because of this lack of awareness, there are a few specialized laboratories that are running these assays. Because of the limited demand for these assays, the cost is really high, and because there is no coverage from the public healthcare system, and also not from private insurance either, then patients have to pay out of pocket these tests, which is very expensive for patients. So very few patients are actually getting this kind of testing. And in even these patients that are getting exome sequencing for diagnosis, a lot of these samples are being sent out of the country. They're being sent out to the US, to Germany, to Korea to get tested in large-scale companies. And we are not getting that data back, because most times the clinicians will get the report, whether it's a positive or a negative report, but they don't tend to ask for the data back. So we are also losing that genomic information that could be very valuable to build databases and also to identify whether a variant is really a variant of unknown significance or it's a polymorphism in our population. I mentioned there's a high cost and low availability and low offer for these tests. And also, this is also reinforced by poor policymaker support and legislators that are not just not supportive, but also not very educated about these technologies. And they think that these are technologies that are happening in other places, in other countries, but not that can be applied to Mexico or to other countries in Latin America. So for all practical purposes, this could be happening in Mars, and it's not just going to happen in Latin America. So to address this issue and to start providing proof of concept data that we can do these projects in Mexico, and also what is the value of implementing genomic diagnostics in the Mexican population for rare diseases. So in 2020, we created the Mexican Network for Rare Diseases. This is a collaborative network of clinicians and researchers and patient organizations that were working to increase awareness about molecular testing and genomic diagnostics. And the focus of the project and of this network is to enable access to genetic testing for patients with suspected genetic disorders. We have partnered with clinicians that are seeing these patients either in public hospitals in their private practice, and they know these patients they have evaluated these patients for genetic conditions, but the patients cannot afford the sequencing. They know that they could be diagnosed potentially with having exome sequencing. In Mexico, the most you can get in the public healthcare system is getting a karyotype. So most of these patients will have a karyotype, but that's about where the testing stops. So in order to bridge this gap, we are providing at no cost exome sequencing, research-based exome sequencing on a trio design, to identify variants associated with genetic conditions in these patients. So we launched this Rare and Undiagnosed Diseases Genomic Sequencing Program in January of 2022. And we get the referral of the patients from medical geneticists that are part of this Mexican Network for Rare Diseases. And we are performing, as I mentioned, trio exome sequencing in collaboration with Baylor College of Medicine and the Tec de Monterrey. We're trying to keep as much as possible the samples in the country and processing and doing everything in the country. For whole genome sequencing, we are collaborating with Baylor because we cannot afford to do whole genome sequencing in Mexico. And then all the analysis and follow-up is performed at the International Laboratory for Human Genome Research. We also have started functional modeling using a C. elegans platform for neurological conditions. So when we have variants of unknown significance and the gene is well conserved in the worm, then we can start doing some functional modeling. So as I mentioned, we started this project in January of 2022, and we recruited the first patients there. So far we have about 30% of the families with a diagnosis having variants in known genes. However, even in these cases, we have several novel variants that haven't been reported, or some that when we initially found them, they hadn't been reported and have subsequently been reported. And also we have 30% of the cases with novel candidate genes that we are trying to follow up and do research on these genes to see if they are actually causative, and 40% of the cases where we don't have an actual lead, a candidate, or a diagnosis from a known gene, as has been mentioned before. So those would be candidate for whole genome sequencing, which is something that we are exploring at the moment to bring in whole genome sequencing platform locally to start doing whole genomes in Mexico. We also, as I mentioned, have the Rare Disease Patient Registry, which was launched on Rare Disease Day of 2022. And we also hold an annual International Rare Disease Day Symposium. And we do activities to educate and raise awareness about rare diseases in Mexico. So as an example of some of the results that we're having and the difference that we are making in these patients, so this is a young patient from Sonora, Mexico, which is a northern state. So he was referred to us for autism spectrum disorder, developmental delay, sleep disorder, speech delay, which was one of the major concerns. He had hearing testing to see if the speech delay was due to hearing problem. He was fine. He had normal bilateral hearing. You can see there, so I don't think the pointer works, but you can see his head is a little bit prominent. So We noted a little bit of relative macrocephaly with frontal bossing. And as I mentioned, so he had a normal karyotype. And prior to the whole exome sequencing that was performed actually through the rare disease project of G2MC, he had an informative multi-gene panel. So when we performed the trio exome sequencing for this patient, we found a de novo variant in ERF. And this gene has been associated with a condition known as craniosynostosis type 4. So this was reported in 2013, and you can see over there some of the pictures of the patients reported. So you can see some of the dysmorphic features as well, which also fit what we see in our patient. And ERF is a transcription repressor that regulates different genes, including the ETS2 proto-oncogene, and it represses its transcription, and it's involved in different processes of development and apoptosis. So the patients that had been reported with this condition have multiple suture synostosis, craniofacial dysmorphisms, which you can see there, language delay, learning difficulties, and hyperactivity. 86% of the patients have learning difficulties and especially problems with language acquisition, which is consistent with our patient. And in this 2013 paper, they also reported this knockdown mouse model where they showed that these null LOXP ERF mice have these craniosynostosis of multiple sutures, and they have also a more rounded, domed skull, as you can see in the figures there. So with this molecular diagnosis in hand, so we went back because, again, the patient hadn't had a diagnosis of craniosynostosis, so we referred him back to neurology and asked them to check if he had actually craniosynostosis. And you can see there the skull imaging, he has craniosynostosis, so this confirmed the molecular diagnosis that we found through exome sequencing. And here in the other panel, you can see the 2 base pair deletion, which is actually a recurrent de novo mutation in this gene, and was actually one of the reported mutations in the original paper. So we returned this result to the family. We had a counseling session with them remotely because they are in Sonora. And to me, one of the main things that impacted from this particular case was the effect that receiving these results has in the family. So the parents thanked us for the result, and they said, we thank you for getting this answer because that helped us to understand our kid. We know that it's not that he's lazy, that he doesn't want to learn, that he doesn't want to learn at school. He has a condition that makes it more difficult for him, and now we can understand as parents and help him with his development. So, so we have seen some versions of this map throughout the conference, but the main theme here is that you can see a lot of the South is underrepresented, so a lot of Africa, South America, and this had been mentioned before. So most of the data that we have in genomics is of European ancestry individuals. So this is as of yesterday. And you can see here that only 0.34% of the genomic data is from Hispanic or Latin American individuals. So we know that we have a problem with diversity, with representation of these populations, and this increases disparities between populations. We know that the lack of reference data impacts how we can return results to patients with genetic conditions because we don't have good reference panels. We have a lot of variants of unknown significance because we don't have good frequency data for other populations. So with that in mind, and also the needs of patients, not just in Mexico, but in the broader Latin American region. So in 2020, we started this regional initiative for rare diseases in Latin America and the Caribbean. we changed the name because in Spanish, rare has a negative connotation, so we now try to handle the low prevalence disease term, which is more accepted by patients. But basically, we try to focus on the major themes that affect patients in Latin America. So we have working groups on legislation and regulation in Latin America, collaborative research networks, access to molecular diagnosis, to information and digital technologies, to integral care and centers of excellence to treat rare diseases, access to clinical trials, therapies, and treatments, education, outreach, and training, and diversity, equity, and representation of indigenous and vulnerable groups. So again, this is trying to address a lot of the issues, not just the diagnosis. Personally, as a geneticist, I focus very strongly on enabling molecular diagnosis in Latin America, but we are trying as a community, as a collaborative, to address all of these issues that are important for the rare disease community in Latin America. So ultimately, again, we've seen throughout the conference that we have the technologies, that we know how to use these technologies, but ultimately the question is that we use them for everyone that needs to have these technologies applied to find an answer for their condition. So the ultimate goal, I think, that we should all strive as a community is that every patient with a suspected genetic disorder should be able to get an accurate and timely diagnosis, no matter where they were born, where they live, or what their socioeconomic status is. And with that, so I'll thank my lab, Remexer collaborators, and other international collaborators. We also work with a lot of the networks previously mentioned, the UDNI, G2MC, the WHO Network for Rare Diseases, to try to bring all of these technologies within the Latin American region to make it sustainable long-term for patients to get diagnosis and also to enable precision medicine. Thank you.
Thank you so much, Claudia. I really enjoyed your talk. I feel like I fly to Mexico. Very nice, yeah. So last but not least, my long-term friend, Dr. Gabriela Repetto from the University of Desarrollo from Chile. So Dr. Gabriela is a professor in genetics at the Faculty of Medicine. Her research focuses on the rare and undiagnosed disorder and implementation strategy to improve access to genomic medicine in resource-limited countries. And she's also on the technical advisory group on genomics at the WHO, and also the chair of Global Genomic Medicine Consortium. So, my dear friend.
Thank you, Duang. We hadn't seen each other in 27 years, so this has been like a fabulous reunion here. Thank you for the introduction, and thank you to the organizers for the invitation. We're going to move from North to South America now, but there will be, I think, a lot in common, and as Claudia said, a lot in common with other regions of the world. So I will share what we have been doing in the area of rare diseases in Chile. And as Claudia said, there's millions of people suffering from rare diseases around the world, and 50 to 60 million estimated in the Americas. And patients with rare diseases face many struggles, as do the healthcare teams and the healthcare systems. And one of them, of course, is the access to timely and accurate diagnosis. So this is a map drawn from the Genetic Testing Registry, which, as you know, is a voluntary resource for clinical laboratories to list themselves and the services they provide. And if you look at this map of the Americas, in Latin America and the Caribbean, there are very few clinical genetic laboratories in few countries, and those are usually less in the single-digit range. range. So this is definitely an important gap in the region. And also, similar to what Claudia said, there are many barriers to access to genomic diagnostic testing. We pay higher costs. We have a number of intermediaries in the region in the purchasing process, and the same thing for technical services, which leads to limitation of local capacities, low volumes, not because of low need, but because of underutilization, and a lack of financial coverage by most of the health systems in the region. Probably Brazil is one of the few exceptions in Latin America. So this leaves patients either not reaching a diagnosis, or the alternative, many of you are familiar with the term of helicopter science. We have called this courier diagnosis, where samples are, diagnostic testing is being done abroad, and sometimes we get results back, but there's no ownership of or return of the actual raw data. So with this situation in mind, we created what we call the Deciphered program for decoding complex inherited phenotypes in rare disorders, aimed at implementing what we call a hybrid model of genomic analysis for patients with undiagnosed diseases, not every rare diseases, that would present with the usual manifestations, multiple congenital anomalies, or neurodevelopmental disorders, or immune dysfunction, but not only doing the genetic testing, but also looking at personal, clinical, and health system effects in a scenario of limited genomic resources, as is the situation in Chile. So what do we call the hybrid model? This is where the clinical diagnostic evaluation is performed locally, but exome sequencing is outsourced to abroad due to limited capacities, but then we receive the data back and do all the analysis locally. We've used a couple of commercial interpretation analysis platforms, but we've also use a lot of the generously publicly available resources that the genetic community has. And so how have we built this program? So what do you do when you don't have any local training opportunities? And as we have heard over and over in this meeting, international collaboration is key, and we're really very thankful to Dr. Jen Posey and Nara Sobrera from Baylor and Hopkins that have received members of our teams for training, and they've gone to Chile also to work with us, and we've done sort of cross interpretations and proficiency testing, and that has allowed for our capacities to grow. And now we've also had some members of our team visit centers in Spain. The other relevant issue is to have a multidisciplinary team, so engaging a number of clinicians with different expertise, and of course the laboratory and the informatics scientists, so bringing all of them bringing their relevant knowledge to the table. And we've also worked in having geographic representation throughout the country, so the regions that have a circle next to them are the ones that we're receiving, that we have participants in. We haven't reached the extremes of the country, but we're working on that. And of course, we want to have sustainability of the program, and that requires, funding and other things, but also having the younger generation getting involved very early in their training. So we've been looking to have a large number of medical students really participating in the program. So as of 2 months ago, we completed the first 150 probands. We are inviting them for trio sequencing. So we've had close to 230 relatives. The mean age of the study entry is about 7 years, with a range of newborn to 52 years, so people having gone for decades without a diagnosis. And most of them have a combination of congenital anomalies and neurodevelopmental disorders, as is seen in other similar cohorts, but also a good percentage have immune disorders as their presenting manifestation. So we have been able to return results to 41% of them because of the heterogeneous nature of our cohort. Everybody has had a unique diagnosis, and both SMVs and CMVs have been detected. And out of those 41, half of them have been variants that have been previously reported in the literature, but about half of them have not been reported priorly. So we've been happy to submit those to ClinVar. And for the other almost 60%, we've also been identifying what could be potential novel candidate genes. And again, the Gene Matcher network has been amazing in helping us put in contact with other researchers and start novel collaborations to try to contribute to the discovery of potential novel genes. We've also done analysis on potential secondary findings using the ACMG version 3.2 list, and we found that 7.7% of probants had a secondary finding, and we look at the overall cohort, it's a little bit higher because there have been some findings from the parents that were not transmitted to the children. And we've been surprised that we have a recurrent variant in the TTR gene, not the common variant, but the second most common variant. And amyloidosis is a disease that's completely underdiagnosed in Chile. So that's helping us decide on another line of development there and looking for those patients. But we do not only want to stop at genetic diagnosis, and as she said at the beginning, living with a rare disease is a complex situation. So we have been lucky to team up with researchers from the social sciences and looking at other aspects of the needs of patients with rare diseases. So this is just one. I'm just going to highlight just a few components of this other part of the project, but one of them is the huge number of hospitalizations that patients have. The majority of our patients are under 10 years of age, and over 80% of them have been hospitalized at least once. And if you count the number of days being hospitalized during that period of time, it's about half a year as a median. We're trying to tease out how much of this has to do with the diagnostic workup versus the symptomatic treatment, and how much of that could have been averted by an earlier diagnosis, and that's work in process. And they're seeing about five different physicians per year and a number of other healthcare specialists. So the cost, the personal and direct and indirect costs are huge for these families. And can't see this very well, but we're also doing qualitative studies trying to understand the complexities of the patient journey in the system. And many of us have seen slides describing the diagnostic odyssey that is described as very exhausting, cumbersome, and some of our patients have even described as violent in the way that they're treated and not trusted by the clinicians. But that doesn't end there, because even if a diagnosis is found, the question is whether there is a therapy available, if the therapy is symptomatic or not, if the therapy not only exists but can be provided to that patient, and if that happens, if the expected benefits do happen. So this is really a very complex loop and a very complex situation for the families. The caregivers are also very crucial persons in the life cycle of the persons with rare diseases, and we've also been doing surveys of some of these caregivers to try to understand their situation and their needs. So we have had studies of almost 500 participants, some from our cohort of undiagnosed patients and others from other patients with other rare diseases but that have reached a diagnosis. And caregivers, it's a very feminized job. 90% of the caregivers are women, mothers, siblings, or daughters. And when we ask them for their perceived healthcare state, this is the visual analog state, a scale of the EQ5D, where people can rate themselves between 0, which is the worst possible health state and 100 being the best possible health state they can imagine, the caregivers rate themselves around 57 as a median. And this really compares very dramatically with other studies that have been carried out in Chile in terms of quality of life, where other groups have interviewed adults during the COVID confinement, or adults with other chronic diseases that participate in our national health survey, and they score higher in their perceived quality of life than the caregivers. And they describe themselves as tired, busy, sad, angry, with anxiety, and with depression. So it's not only the person with a rare disease, but their surroundings that are having a really relevant impact in their life. So what are the perceived needs of caregivers? Financial support, health information. That's, I think, something that we should take on as a team. Mental health support, and also legal advice. And this is shared by the great majority of the caregivers. So of course, these needs have complex solutions, and most of them at the individual level. But still, we've been trying to work with the patient and their associations. For example, doing a series of webinars, trying to address some of these needs. Legal advice, what are the benefits that they are entitled to, or what are some options that might help them as a community to build mental health strength. So we've had about 20 of those. If you're interested, there's the link to the YouTube channel where all of these are stored, and it has been a really fantastic experience where we usually have like a triad of a patient or caregiver, somebody from academia, and somebody else depending on the topic, and really coming together to hear all of these different perspectives and try to identify potential solutions that have a local relevance. And we've also moved beyond the clinic to public policy. Because these are things that do need wider solutions. So in 2021, we were convened by now a former Senator, Carolina Goich, to build a proposal for a national plan for rare disorders. Over 100 persons participated in it from multiple areas, and identified some of the priorities. This proposal was presented to the Ministry of Health a couple of years ago, and since then we have seen slow gains in the country. There's finally, as of this year, a rare and complex chronic diseases office within the Ministry of Health, so patients know who to approach. We're having a law that's being discussed in Congress at this time, and for the first time we have started to have conversations with the public payers about costing and potential funding for genomic testing, and that will definitely circle back into improved chances for local implementation. And even further, so one of the common themes across this meeting is the lack of representation of genomic variation across different parts of the world. So and that has been a crucial need for our program. So one of the things we did was a crowdsourcing initiative from different research projects at our institutions, our program, rare diseases, but other common diseases as well, and pulled together all of the control samples that in each of our in each of our projects, and built what we're temporarily called XSACH, which is the Chilean Exome Aggregation Initiative. We're coming up with a better name soon. So we reached about 1,000 exomes so far, and if you look here, the number of novel variants that we find in our database compared to others, that's when we compare to Genome version 3, there were about 27,000 variants that were not in our database that were not represented there. And now even with the version 4, we still have about 17,000 novel variants that are not represented there. So this, go back. So we really hope, this has been a really, really useful resource for us, and we're also hoping to make it publicly available soon. And of course, it's been super useful. We've had, it helps a lot in our filtering of variants, both for in our rare diseases project, but also for our colleagues working in cancer. This really saves us a lot of time and not going after variants that are really common and are absent from other databases, but very common in our population. So to summarize, what have we learned? It's been a challenge to start this program, to sustain it, and we're also looking at the next growth phases. So for one thing, is not to wait to have every single portion of your needs already put in place. You can take risks, and this hybrid model has been, I think, a good intermediate step for us that has allowed us to generate local capacities in interpretation and be ready when we hope we'll have the local sequencing capacities. Of course, collaboration is key. It has allowed us to have global training opportunities, and of course, this interdisciplinary approach in trying to understand rare diseases from a more holistic perspective, and also, again, allowed us to build this database. And the implementation, of course, requires local data, so this is something that we have been, I think, very grateful that we've been able to produce this information. So what are our future steps? One, we hope to soon be able to transfer what we're doing to a clinical lab. I always say that a measure of success of our program is that nobody will need to get an exam in a research study, but that it will be done and covered for in the adequate clinical setting where it belongs. Our process has allowed us to identify, significant bottlenecks. So hopefully when we, turn this over to clinical labs, we'll be able to have good information for them. And that will probably mean that we'll refocus the program on the cases that remain unsolved, and with the tools that we've already heard about, reanalysis and the incorporation of other technologies. We're also working on developing capacities for functional studies. We have a really strong immunology program, and I think we're going to focus it on that. I always say the immunologists have their functional studies just a blood draw away, so that's probably a feasible thing for us to do. And of course, again, with all of this other data that we've been accruing, I really have the mandate really to generate healthcare programs that are more comprehensive for people with rare diseases. And I just want to finish thanking the great number of our collaborators, the patients and families that have trusted our program, and of course the funding agencies. And you can find links to the webinars I showed you earlier and some of our publications. Thank you very much.
Thank you so much. Lots of work. Thank you. And before I invite the speaker to the podium, I have some housekeeping to announce. So our sponsor, PacBio and LiveBit, warmly invite you to the evening network sessions immediately following today's program. So join them at the special evening to connect with industry leader, expert, and professional. And also, after the tea break, there are 2 parallel sessions, Genomics and Precision Medicine and Rare Disease and Therapeutics. And the other is a session curated for early career investigator. And, lastly, there is also a panel discussion sponsored by Nala Genetics in the Wisteria and Camellia Villas at 4 p.m. And please don't forget to provide your feedback by scanning the QR code shown on the screen. Yep. All right, now, welcome. I would like to invite all the speakers to the front again. Yeah, thank you. All right. Yeah. So, all right, here we are. All right. Questions to Dr. Jamuar first? Okay. All right. How does the 3D photography tech you presented handle disease with variable expression? Right? Because not all disease will have the classic phenotype,
So that's a great question, and that's actually the running part, which we haven't gotten to yet. So we are still trying to learn how to walk, and that is by understanding how we can accurately capture the dysmorphic features. The advantage we have today is that we have Gen AI to help us give some of the answers to and again, with large language models, they do have that a breadth of knowledge in terms of variable expressivity. But we are not there yet, and the example is that I took 6 patients with Noonan syndrome, which were clinically confirmed. I did use 3D photography, extracted the dysmorphic features using the Asian reference, and Noonan syndrome was identified as the number 9 diagnosis in only 1 of the patients. Everyone else had 10 different differential diagnoses. So we are not anywhere close to that yet. So I think understanding the variable expression in terms of facial signature, I think that's going to come, but we are not there yet.
All right, so he invites for more collaboration from Asian country.
Absolutely, and Latin America. Yeah.
Okay, all right, so keep that in mind, and thank you. And the next question is, they are curious about to know how is the sample volume in Singapore compared to the other countries doing rare disease?
I would assume it should be the same, which is 5 to 8%. But I mean, I think it depends on the country, and I think as demonstrated, I think that there are some countries obviously where the referral system and the accessibility to genomic testing is much more robust. So in Singapore, I would say that back in 2014, we were struggling, we weren't getting, but now, because we are able to demonstrate that we can get the diagnosis, so we are getting more referrals for these diagnoses. And the example I gave is that we set up what we call rapid sequencing for patients in ICU, and we could get the results back in 5 days. So still not very rapid, but 5 days was. And what happened was that the intensivists were referring to us first before referring to the neurologist, the respiratory physician, all that. I was like, no, let's sort those out first, get an MRI first before you refer to me. But yeah, that's how it's changed. So we are getting more referrals, but I think it's still not there. We're not seeing all of them.
Yeah, I think we also get a lot of consult from ICU and NICU, right, quite early. Thank you. And next one. Okay. I think are rare disease more likely to be Mendelian disease? And so is it possible to imply linkage disequilibrium analysis to these situations? I mean, any of the speaker can help. Yeah.
So thank you. Yeah. So most of due to demographic reasons, most of our families are small, as that happening in the majority of the world, and most of the variants that we see are de novo. So this is so going after the direct finding through sequencing. It's a more efficacious way. Yeah.
Okay.
I don't know if that was the issue raised by the question.
Yeah. I mean, here I think if the question is about like applying linkage studies, linkage analysis,
disequilibrium study.
Yeah. So same. Most of the patients that we get are affected child and affected parents. So usually, de novo mutations, sometimes recessive conditions, but we don't see large pedigrees.
Right. Anything else to add, Saumya?
No, I mean, I think just agree with them. And I think linkage was a very powerful tool 20 years back when we didn't have these tools, where we would do Sanger sequencing or candidate gene sequencing to identify what the cause was. But now with exome, genome, long read sequencing, relatively easy accessible, it's less. I think linkage comes in when you do have a variant of uncertain significance, and then you want to test the extended family members to ascertain whether that is pathogenic or not pathogenic. So, but not, yeah. But yes.
Totally agree with that. And the next question is, how do you decide which patients to initiate or advocate for N-of-1 trials therapeutics? That's probably...
I think anyone can audit on, but
Yeah.
okay, maybe I'll go first. And so I think this is a $1 million question because it literally takes $1 million to do that trial, right? So with everything else, you have to follow the money sometimes, unfortunately. And there are some patient organizations that have been very successful in raising the funds. So the first is there funding available, either from a patient organization or a research? From a research entity, especially in this part of the world, the focus is on common diseases, not so much on rare diseases, so we don't get much money to find treatments for patients with rare diseases, especially N-of-1. So that's funding. The second is the disease, right? Or more, before that is what's the modality that you want to use to treat? Is it enzyme replacement? Is it CRISPR, Cas9? Is it base editing? Is it antisense oligonucleotides? So depending on the different aspects, you would decide on what is, or mRNA, what is the best disease to treat. And so then if you decide on the disease, what is the manifestation of the disease? Is it multisystemic or single system? If it's single system, like a neurological disease, is there an effective delivery mechanism for the modality that you want to use? So if it's mRNA doesn't work in the CNS. The delivery system doesn't work, so it's not a good therapeutic. But ASOs do, so you just need saline to inject the ASOs. So that would be, yeah. And then I think it's always helpful if you can treat a group of patients rather than a single patient. So again, the numbers matter as well. So those will be the sort of the broad principles I think of.
That's right. That will be more financially challenging in the future as well, yeah, for the treatment.
Yeah, so I think Jeanette, who's in the audience, I mean, she's got a patient, two patients who have this gene therapy that's ready to go, but each family needs to raise $3 million to get that going, and it's very hard.
All right, thank you. So the next question is for Dr. Repetto. Okay. The question is, for the hybrid model, how long did it take your in-house dry lab? Okay, how long does it take your in-house dry lab team to, to be competent and independent? And how many BI? Bioinformatician and variant scientists do you have? Yeah.
Yeah, that's, when do you really feel competent or independent? It's a very hard question when you don't have local proficiency programs. But I think we paired our samples with a team at Baylor, I think for the first 20 to 30 samples or so. And to make sure that we were consistent, but that's, a number that I'm pulling out of my hat. Of course, we should be participating in formal proficiency programs. In terms of bioinformatics, we have two in the team that are really amazing. And variant scientists, that profession that doesn't exist in Chile per se, so we were all considering ourselves variant scientists for the purpose of our Friday meeting. So we do a lot of the manual curation as a team, but also thinking about having somebody go abroad and train formally in that, because I think that would definitely make the system much more efficient.
Okay, I think that's probably the same in some institute in Thailand. We have mini variant scientists, sort of, not the real person.
If I can just add something to that. So I think one of the advantages we have today is YouTube. And we have resources on YouTube. And one of the resources that I go to is ClinGen. because ClinGen puts all these resources on YouTube. So they have these monthly calls, which happens at 2 a.m. Singapore time, so I can never attend them. But I always follow them up the following week because they are brilliant and they cover each aspect of variant interpretation. There's a specific group that looks at variant interpretation, and I think that's a great place to learn because that's where the guidelines are being formed. So watching those YouTube videos is helpful.
Okay. Besides from YouTube, we can do collaboration in the region, I think. Yeah. Right.
Yeah, I'll just add for the trainees and students. So currently there's open for the Welcome Connecting Science courses. So there's actually a course on variant interpretation in diverse populations. So it's a very good course if you guys want to take it.
And it's free.
Thank you.
Yes.
It's free. The most important thing, it's free, right? Okay. We have no time left. All right. Oh, thank you so much for being with us at the end. So give thanks to the speakers.